You're listening to Boomers Today with your host, Frank Sampson.
Well, welcome to Boomers Today. I'm your host, Frank Sampson. Of course, each week we bring you important and very useful information on issues facing baby boomers, their parents, and other loved ones. And I want to thank everybody, as I do each week, for participating in our podcast and sharing individual podcasts, as well as the entire show of podcasts to friends and family. That's why our listeners are growing each and every day. Many of you listen to the show on Google Podcasts, Apple Podcasts, Spreaker, Stitcher, iHeartRadio, many of the other podcast stations we're on. Some of you go right to our website at boomerstodayradio.com. So again, thank you so much. I know why our listeners are growing every day is because we have great guests, very knowledgeable. We're not going to disappoint you today. We have with us Dr. Gerda Maissel, who is the go-to person to repair medical nightmares. Dr. Gerda is board certified as both a physical medicine and rehabilitation physician specialist and a patient advocate. She helps people with complicated medical problems, often in the hospital or rehabilitation center, getting the best care possible. So Dr. Maissel, thank you so much for joining us on Boomers Today. Really appreciate it.
Thank you, Frank. Great to be here.
Yeah, so, your role is quite unique. I mean, you're a doctor, you're a patient advocate, so we're going to learn more about what you do. So maybe we could just start out on the patient advocacy side and maybe help educate our listeners kind of what exactly does a patient advocate do, and maybe more specifically, what do you do in that role, knowing that you're a physician as well?
Sure. Well, thank you for asking that. So a patient advocate helps individual patients or their families with healthcare issues. So it really breaks down into two camps. One are patient advocates that do things like I do, which comes down to medical navigation. The other group of patient advocates help people with billing problems because it can be so difficult to deal with all the bills you get, to do appeals, to battle the insurance company. Because I'm a physician, I am squarely in the help people with difficult medical problems camp.
Gotcha. Well, that's great. So what about coordination with doctors? I mean, people go not just to their primary care physician, but they end up going to specialists, and maybe they have one doctor providing medications and another doctor prescribing other medications, and just having somebody kind of bring it all together and make sure that communication is happening. And, as you know, and we see in the work that we do, that sometimes the medications are the problem and not the fix. So thoughts there, or maybe you could just share a little bit about that.
Well, there was a lot in that question there.
Yeah, there was.
So
yeah.
One issue that you raised is what we call polypharmacy, which is many drugs. And I've had a number of clients use me to take a look at their 30 plus drugs their loved one is on, knowing that when someone is on 30 plus drugs or even 20 plus drugs, the chances of what we call adverse drug events, which can be side effects or bad drug interactions, are extremely high. And I've certainly helped a number of people with that kind of problem. Sometimes those are people in nursing homes where somebody just keeps getting more and more drugs added. Sometimes those are people in the community who have 10 doctors that don't talk to each other. And a doctor just prescribes for their particular, what I call the left big toe ailment. They're only seeing the left big toe and they're not even seeing the foot, never mind the leg of the person they're prescribing for. But then within that, you asked, I think in the very beginning of that, coordination of care. And especially in the outpatient arena, people can have a dozen different doctors, and doctors are not paid to coordinate care. They're paid to do an interaction, often prescribe something, but let's say treat and move on to the next person. By and large, I'm oversimplifying. And they're not paid to talk to all of the other specialists and primary care around them. And so the role of coordinating care often falls to primary care doctors. And those primary care doctors are typically overworked, underpaid, and overwhelmed, and they don't have the time to do the care coordination necessary.
So I don't want to get you into any trouble with all your doctor friends and those that you work with, but what can, any recommendations you have to the medical community on how they can do a better job in coordinating care?
Well, recommending to the medical community is one concept, which comes down to interdisciplinary conferences, which sometimes happen in rehabs or cancer centers. But the reality is that coordinated care is going to fall to the family, the patient themselves, if they're able, and to the family. And the more that a family can keep records, can keep track of the different recommendations, or use a medical navigator, a medical advocate like myself, the better chances are not just that they're going to understand, oh, Dr. A said do this, Dr. B said do that, but they're going to bring the right information to the right specialist in the right way to get better care.
Right. So how do, I mean, the people that hire you, what's the makeup? Are you usually brought in during a crisis, or people just going, it'd be great to bring you on to help us. My mom is seeing various doctors. She's on a lot of medications, and we just need somebody to evaluate. Or is it a crisis situation? A problem has occurred, and that's when you're brought in.
So it's both. I love a good crisis because personally, what I get out of that is I feel really useful when I get involved with somebody who is often, the family member's been in the hospital for, can be a long time. It can be a week, 2 weeks, 3 weeks, or longer. And the family has tried everything they know, and they've gotten frustrated with the doc of the day, the hospitalist of the day, who doesn't seem to know, let's say, their mother. And they aren't sure if the care is the right care, and they need somebody who speaks doctor to really both help talk to the doctors, help them understand, and help them make fully informed choices for their parent or their spouse or whomever. And then sometimes I do get brought in when it's less of a crisis. I recently had somebody hire me simply because his mother, we're back to the polypharmacy issue, but his mother was on, I think she was on 23 different medications. And he, even though he had a geriatric care manager in there, polypharmacy wasn't her expertise, and he wanted me as a physician to look at things, look at the different specialists, figure out what could be done to help his mom live a better quality of life for her remaining time. Mom has her, in this particular case that I'm referencing, mom has dementia and sometimes has some difficulties, but he wasn't sure, were some of these difficulties from drug side effects, from too many medicines, or even from certain care issues that he was concerned about in the facility.
In most cases, are you communicating directly with their doctors?
Oh, yes, frequently. In this last one that I mentioned, they selected to go through the existing geriatric care manager and the relationship that was already there, which makes tons of sense. But most of the time, yeah, I actually do communicate with the doctors either through a separate phone call or by attending medical appointments. And I often do that virtually. And when I attend the medical appointments, people often worry, is the doctor going to be resentful of this other doctor? And that's where you have to be tactful. I don't come in all, telling any doctor what to do. What I do is I know what they're going to need to know, and I give them that information in a very condensed way so that that doctor says, oh, this person is saving me time, giving me the right information and asking a question or two that now I'm freed up to have time enough to ask. So I give to the doctor in order to get a better response that then ultimately helps the patient, the client.
So there's so many specialists out there. Um, what recommendations do you have when someone, obviously, Google and other search engines can be quite informative, but also could be a negative too, especially if somebody has an ache and pain and they go onto Google and they do a search and there's kind of almost self-diagnosing themselves and they go, oh, I need this kind of doctor. All right. Uh, is it your recommendation that people should go directly to those specialists or go to their primary care physician first, or combination of? What's your recommendation on who they should go to for what? And I know that's a loaded question too, but
Well,
yeah.
I have huge respect for primary care doctors who have very, very difficult work, because so much work falls on a primary care doctor's shoulders that frankly other doctors don't want to do, and they say talk to your primary care about it. So I think when it comes to using primary care or a specialist, it depends on how easy it is for you to access your primary care. It depends on the knowledge base of that particular primary care. Doctors are human beings, and some doctors know a lot of neurology, for example, and others don't know much about it at all. And so I think whether you go to primary care, my general thought is yes, start with primary care. You don't have to go to a specialist for every minor issue. But on the other hand, I think there's nothing wrong with using a specialist when it is something where you're going to get a deeper dive and a more sophisticated answer in a more timely way.
Yeah, I think that you said it earlier that primary care physicians are quite busy. I mean, most doctors are, but especially primary care physicians. And I'm just speaking from experience or experience of friends and relatives that go, I can't even get in to see they can't see me for 2-3 weeks. I got to get this taken care of, and I can't get a hold of her, and I can't get a call back from him, or whatever the case may be. So I think that's the frustration of many. Would you agree with that, or how do you deal with, hey, I want to get to that primary care physician, but I got a problem I'm very worried about, and I can't even get a call back, or I can't get an appointment.
That's right. Well, and that's where when that happens, I have clients where, I had one client who had a numb, painful foot and had gone to see primary care, and it had gotten worse. And when she called me saying it was worse, we discussed going back to primary care, but she was in so much discomfort and I was concerned about what she was saying. I felt that she needed to have an exam done that day. We discussed emergency room versus urgent care. She ultimately chose urgent care, which I frankly thought was the best choice. They couldn't find a pulse on her foot, sent her to the emergency room, where indeed she had a blood clot in her foot, and she ended up with surgery that night. So there isn't a one size fits all. It all depends on how likely, how dangerous is the problem. And in the kind of symptoms she was exhibiting, there was a potential danger. And so she needed to get to a doctor of some sort that day.
So I want to, we're going to be taking a real quick break in a moment here, but I just want to ask you about those that are having some sort of cognitive issues, elderly person with cognitive issues. And there's different opinions on where do you start with that. Now, maybe you could go to primary care, but if you're going to go to a specialist regarding uh, memory loss, especially short-term memory loss, what's your recommendation? Where do you start?
So for short-term memory loss, actually primary care, if you can get in, it's not an urgent issue, but it's one that you could make an appointment for and start to talk with your primary care about. In terms of if you would like a specialist to work up the condition, there's really two specialists to consider. One is a geriatrician. And part of why I like a geriatrician in a scenario like this is the geriatrician will tend to look comprehensively at whether it's medications, which we've talked a lot about, diet, lifestyle, variety of medical conditions, all of which can contribute to memory loss. The other person that is a good person, or the other specialist that you can go to, is a neurologist. And keep in mind that neurologists have many subspecialists. So you want to find a general neurologist or even a neurologist that is particularly interested in memory loss. Because if you go to the neurologist who does EMGs, which is a type of test all day, they're not going to necessarily give you the workup or the attention that you want. So whenever seeking a specialist like a neurologist where there's lots of subspecialists, ask ahead of time, is this the kind of thing, is memory, if that's what you're looking for, is memory a common thing for this doctor to work up?
Great input. So Dr. Maissel, we're going to take a real quick break, I promise. When we come back, we'll learn more about how people could get a hold of you or your practice, and we're going to talk a little bit about some of the challenges in medical facilities today, hospitals, skilled nursing facilities, staffing, all of that. So that's a big subject matter. So do you have anybody who may be concerned about an older driver? Well, Senior Care Authority's Beyond Driving with Dignity program is a facilitated self-assessment program for older drivers. This program has been designed to serve as a vital tool to facilitate older drivers and their families as they make appropriate decisions regarding the future of one's safe driving career. If the individual is a safe driver, an advisor will provide him or her with strategies on how to remain a safe driver as they progress through the aging process. If driving retirement is the appropriate decision, then the individual and their family are offered possible alternatives, resources, and a specific plan to ensure a smooth and successful transition from the driver's seat to the passenger seat. So to learn more, you can go to www.beyonddrivingwithdignity.com or call 877-907-8841 to connect with a Senior Care Authority advisor in your area. We're back with Dr. Gerda Maissel, who is a board certified as both a physical medicine and rehabilitation physician, a specialist, and a patient advocate. So, Dr. Maissel, so, there's been, I just know this, but you tell me, you correct me if I'm mistaken, but there's a shortage today of good skilled medical workers. I know there's a shortage of caregivers in our country. If you agree with that, then, what would you recommend to people to watch out for? Should they be in the hospital and knowing there is a shortage and maybe the care isn't what it's should be in some places, but how can they be their own advocate, or how can the family be an advocate for their loved one in those situations?
Well, I'm going to answer your question, Frank, on a couple of levels. I think that there certainly has been a turnover and shortage of frontline workers, of aides, of nurses, et cetera. And that's what a lot of people think about when they worry about, is my loved one going to be safe in the hospital? And being present is one of the best things that you can do, whether it's yourself, whether you hire an aide to stay. Some hospitals will let you place an aide, but whether ideally you have somebody there. If you have an older person in the hospital, you have somebody with them as much as possible. But I'll answer your question on a different level, which is one that people don't always think about, which is the way that you get medical care in the hospital has changed dramatically in the last 20 to 30 years. 30 years ago, your primary care doctor came to the hospital and the primary care doctor knew you. Now you have hospitalists in the hospital, which is a really good idea in many ways because they know how the hospital works. But there has also been a shortage of hospitalists. And so back in the day, we used to have hospitalists who would be on for, say, 7 days on, 7 days off. Now with the strain and the shortage, you may only get a hospitalist for a day or 2 days, maybe 3. You often don't see a 7-day stretch anymore. And what that means is that the doctors are fundamentally seeing you using a checkoff list to check on a couple of conditions or labs that the doctor before them gave them, and then they're moving on. So not only do they not know you as a human being, your values, if you have dementia and you can't talk with them, then you're more at risk. And it's hard for the physician to have enough time because of the caseload that they're carrying. They're not going to have enough time to do anything other than make a superficial decision. So I think there is I don't want to be dramatic and say a hidden danger in hospital care these days, but I think that people assume that medical care is always going to be terrific, just like when you take your car to the doctor. I say take your car to the doctor. When you take your car to the mechanic, you just assume the mechanic knows what they're doing. They've deeply diagnosed the problem and all will be well. Well, for many people, medical care is a black box and they just assume whatever that doctor says, they must have read the chart in detail, know all the information and have all the context. And unfortunately, that's just not the case today.
Gotcha. Okay, good. I after break, I meant to first ask you to maybe share with our listeners, your website, anything else you'd like to share and the work that you're doing. Sorry, I failed to do that. So why don't we go ahead and do that now? Why don't you go ahead and share with people?
Oh, sure. Well, my website is easy. It's www.mymdadvisor.com.
Great.
And you can email me if anyone wants to email. I'll give you my direct email, which is GM, which are my initials, at mymdadvisor.com.
Great. Perfect. So you had mentioned, going back, you had mentioned hospitalists. Just for our listeners, why don't you explain what is a hospitalist? What do they do? How can someone access a hospitalist? I know you say that there might be shortages of hospitalists too, but why don't you just kind of explain what they do?
So I'll explain with a little bit of compare and contrast. So 30 years ago, when you were in the hospital, you had a primary care doctor, and that doctor would come to the hospital and round and visit you. They would order your labs, they would take care of you in the hospital. And, that was your doctor. You had a doctor, the same doctor, outpatient and inpatient. The system has evolved for reasons that if you want to talk a lot about hospital medicine, I'm happy to, but the system has evolved so that a hospitalist is a doctor who does not have a panel of patients in the community, doesn't have a practice. Instead, the hospital is where that doctor works. And we now also use the term sniffists for people that work in skilled nursing facilities. And it's the same idea. That is the doctor that works in that location.
So, but they're employed by the hospital.
Yeah, the hospital or the health system that is part of that hospital. They're part of a group practice.
Gotcha. All right, great. So let's get into, if we can, rehab or rehabilitation. I know of our listeners have had loved ones that have had surgeries and had to go into rehab. And I know you have said that there's more than one level of rehab services. So maybe you could discuss that and help us understand that.
Sure. And this is one that people get very confused and frustrated about, even people in the field. So the two levels, one is called acute rehab. It may be called inpatient rehab. The other is subacute rehab, which may be called nursing home rehab. The economic drivers are quite different between the two, as is the requirements for going to either, or what the insurance will allow, as is the expertise. So acute inpatient rehab was the rehab that was designed long ago to have specially trained therapists, specially trained nurses to take care of people with really complicated problems. So you typically see people with spinal cord injury, head injury, stroke. Back years ago, you used to see people with joint replacements, but that doesn't happen anymore. And the stays in acute rehab, because it's expensive, are brief. They're 4 weeks, 6 weeks, occasionally longer. But it's reserved for people with really tough problems. And you have to be able to need, benefit, and participate in 3 hours a day or more of therapy. And that can be a combination of PT, OT, and speech. So what that means is an older person, especially a person who might have some memory loss, often doesn't qualify for acute or inpatient rehab because they may not have the endurance to do 3 hours a day of therapy, or they may not have the ability to what we call carry over. They may not remember, which means they may not benefit from the intensity of acute rehab. Acute rehab comes with a doctor that sees you every day. Subacute rehab, which is done in nursing homes, you're going to have 3 to 5 times a week, not a day, therapy. So it's going to be in subacute. In a nursing home, it's going to be less intense. You'll probably have a nurse practitioner that sees you on a daily basis or a couple times a week. And you will have, it's just a less intense environment. And that doesn't have to be a bad environment. A lot of people say, well, I want everything for mom. Well, if mom is exhausted and can't tolerate all of those people poking and prodding them and trying to get her up and, exercise 3 times a day, a subacute rehab could be a much better place for her. Generally, subacute rehab is going to be measured in many weeks to months in terms of the stay. And Medicare, traditional Medicare, will pay for, if you still qualify, up to 100 days. So think of subacute as a less intense, longer stay in rehab.
And why don't we talk about, because I'm sure, I know we deal with this all the time, and I'm sure you do as well, especially if someone is on Medicare. And there's usually not a whole lot of time to plan from the time that Medicare says, okay, we're done paying, based on the information they receive from rehab. Okay, we're going to be done paying on this Friday. All right, and there might be only 2, 3, 4 days away, and maybe that individual, maybe it's not safe for them to go home, or if they go home, they're going to have to get a caregiver, or they may have to go into some assisted living or something, and everybody's scrambling. So talk to us on how families can better prepare for that instead of having to scramble at the last minute.
Yeah, you're so right, Frank. That scramble is so disorienting and upsetting for families. So one of the ways to avoid the scramble, or at least to anticipate it, is from the beginning, there'll be a care manager, social worker, discharge planner person. Ask them what the anticipated length of stay is. from the beginning. Ask the doctor on a regular basis or the nurse practitioner, how much longer do you think my loved one's going to be here? And, if necessary, ask for a family meeting to discuss what they think is going to happen. And make it a dialogue, not just oh, this is what they said, but hey, did you know that mom has to go up a flight of stairs in order to go home? So can we really focus on stair climbing? Oh, okay. It should be a dialogue around discharge planning. And often, unfortunately, in the scramble, it doesn't feel like a dialogue.
Great. Dr. Gerda Maissel, thank you so much. Check her out at mymdadvisor.com. Thanks for joining us on Boomers Today. Really appreciate it. And I want to thank you, everybody. Please be safe, and we'll talk to everybody next week.
You've been listening to Boomers Today with Frank Sampson. To learn more about today's show, visit boomerstodayradio.com and join us next time for another edition of Boomers Today.